When the light is on, the mic is on. When you're speaking.
Representatives Capley, Sapicki, Davis, Freeman, Haynes, Hemmer, Hicks, Johnson Montgomery, Johnson O'Knox, Lafferty, Mitchell, Ritchie, Rudd, Rudder, Sparks, Terry, Thompson, Vice Chairman Martin, Chairman Kumar. Mr. Chairman, you have a quorum.
Thank you, Mr. Chairman and members. House Bill 57 is an administration bill from the Department of Commerce and Insurance. This bill sets the group capital calculation and liquidity stress test requirements for insurance companies. The bill also gives the commissioner the authority to require insurance companies deemed to be in hazardous condition to secure and maintain a bond or deposit. And my understanding is there are no amendments to the bill, Mr. Chairman.
Thank you. The question's been called without objection. We are voting on House Bill 57. All those in favor, please say aye. Opposed? The bill moves on to the full calendar and rules. Thank you.
Thank you, Mr. Chairman and members.
The next item on our agenda, our presentation about the important subject of prior authorization, also known as pre-certification of procedures and treatments that have to be obtained from insurance companies before patients are treated. The function is usually carried out by the healthcare providers. We have three organizations who are going to explain the process and their side of it. The first on our agenda is the Tennessee Medical Association. We will move out of session. Thank you. Welcome, ladies and gentlemen. Kindly, you know the routine. Kindly introduce yourself and start.
Julie Griffin, Vice President of Government Affairs for the Tennessee Medical Association.
Natalie Dixon, President of Tennessee Oncology and Chair of the Insurance Issues Committee for TME.
And hi, everybody. Stephen Schleicher, practicing medical oncologist and Chief Medical Officer at Tennessee Oncology and past president of the Tennessee Oncology Practice Society and member of TMA. Thank you for your time today.
Mr. Chairman, members of the committee, I want to thank you all for taking the opportunity to let us talk about an issue that is of great importance to not just the members of the Tennessee Medical Association, but I dare say to many, if not most, of your constituents. Many of you probably yourself have experienced having to get a prior authorization for a service, but I know most of your constituents have had to do so. And in doing so, it has turned into something that has caused delays in care and in many instances harm to patients. So with that, I'm going to turn it over to Dr. Dixon to start the presentation.
So thank you, Chairman Kumar and members of the committee for having us here today to kind of give you an overview of prior authorization and how it affects our patients, their outcomes, the practices, and our communities in general. So what is prior authorization? Some people refer to it as pre-certification, but it's a process and procedure that the health plans use to obtain advance approval before a provider can provide a service or provide equipment or deliver treatment. Each insurance plan has its own process for doing this and has different services and different drugs on these lists. So after we, as physicians, order service or a drug for a patient, we have to then contact the insurer to determine if a prior authorization is required. If it is required, then the process that we have to go through varies from one insurance plan to another. And it usually involves completing a form, and the form, again, is different for each insurance provider. So upon review of the request, it can either be approved, rejected, or additional information is required. If the service is rejected, then we would have to file an appeal, and this appeal may or may not involve a third party. And again, each insurer has its own appeals process. And in some cases, this appeal process may take up to 30 days. During this time, patients may abandon their treatment. They may seek an alternative way of they either end up in the emergency room or they're hospitalized, or their disease or illness may worsen. And as all of this is going on, the trust in their physician's decision is eroded. So employers who have to pay for the medical coverage for their staff members have tried many ways to avoid the high cost of healthcare. And so they look to the payer to help solve this issue. And the payers provide prior authorization as a way to control costs. And so employers believe that prior authorization reduce healthcare costs, and it offers them a way to manage overprescribing or the use of unnecessary medical procedures. However, oftentimes we see payers using prior authorization to hold down costs in the short term, not thinking of the long-term increase in costs that this will result in. As I mentioned before, overutilizing ER and hospitalization visits, and as conditions worsen, then the cost of treatment worsens. Prior authorization also increases administrative burden on our practices. According to a 2021 survey by the AMA, practices complete an average of 41 prior auths per physician each week, which translates about 2 business days of our time. So as an example, in our practice, Tennessee Oncology, in this past year, we have 30 full-time FTEs focused just on prior auth. And in 2022, we had over 120,000 prior auths for our intravenous, intramuscular sub-Q treatments. Only 0.03% of them were denied. In the past 6 months for our oral treatments, we had over 3,800 prior auths. Only 0.4% of them were denied. We had almost 50,000 for scans in the past year, 1% denied. And it cost us, and this figure is inaccurate, it cost us almost 2.5 million in salary and benefits for these 30 FTEs that are just doing prior auth. I'm going to hand over to my colleague, Dr. Schleicher.
Thank you, Dr. Dixon. So go back to that slide real fast, please, Dr. Dixon. So again, one of the advantages for prior auths theoretically is if physicians are doing things incorrectly, it's meant to be a maneuver to help the insurance regulate and make sure that unnecessary treatments aren't being done, et cetera. As this data shows, despite Tennessee Oncology having to do this many, they found in the end only 99.7% were not already appropriate. We had to do the prior auth for all of these. So this data points to the fact that we're not just saying half of our cases are denied, wish we could do it all. We're actually doing the work and finding that less than 5% or maybe 1% of scans are ultimately denied despite us having to do this. So that's why this is such a burden for us. I want to show this is data for all of Tennessee Oncology. I want to show just 3 patient examples because this is what we're seeing on the front lines, and ultimately this is about the patient. This is all patients of Tennessee Oncology. 25-year-old gentleman with glioblastoma. That's a brain cancer. Prognosis is often many months, maybe a year. So that's months of a 25-year-old male to be with family. His drug, which is the clear standard approved drug called temozolomide, was prescribed December 22nd. He was unable to receive that drug till January 13th. That 3.5-week delay might not sound a lot, but when you have months to live, that's a delay getting treatment. Not only does that allow the cancer in the brain to grow, but that is severe anxiety for a patient and a family going through this. Another example, a 52-year-old gentleman with small cell lung cancer, incurable, was on second-line treatment. Again, here, prognosis limited, often many months. The only FDA-approved drug in this standpoint, the only drug is called topotecan. This was ordered December 12th, not received by the patient till January 23rd. That's a 5-6 week delay for a drug that is the only FDA-approved drug, with the patient just waiting there with incurable cancer, knowing that he had, or in this case, a female has, many months, hopefully longer to live. And this drug is meant to prolong that time. And then this is less severe in terms of delay of treatment, but just something we face day to day. A simple scan, a 19-year-old male who had Hodgkin's lymphoma. Every guideline would say you want a PET scan to help you stage and figure out what to do next. This is not some crazy random scan. It's very common. Needed a PET scan. It was denied. So the physician, in order to get the scan done, had to send the patient to the hospital to be admitted just to have a PET scan and a biopsy so we could get treatment for a curable cancer in this 19-year-old man. So in addition to the fact that, as I can speak for Tennessee Oncology, we're right over 99% of the time of what our patient needs, going through these loopholes, and patients are facing these consequences. We think this is a big problem that needs to be addressed. Getting broader than Tennessee Oncology, this was a 2022 survey done by TMA. As you guys might be able to imagine, physicians do not like doing surveys, but in this case, over 50% actually responded, which is a huge number. I can't get that many providers to respond to anything that I asked for as chief medical officer, but this is a big pain point. Out of all those responses, 94% of physicians felt that the burden of prior authorizations was high or extremely high. The average wait time from the survey, over 65% of practices in TMA have to wait more than 3 business days for a decision. And then in terms of what's most important to us, clinical outcomes for our patients, 95% of Tennessee physicians perceive prior authorizations to have a significant or somewhat significant negative impact on patient clinical outcomes. Just another anecdote, I had a patient with known cancer who came in with severe neck swelling. I needed a CAT scan and couldn't get it because I had to wait to talk to an insurance person on the phone to get that scan to evaluate the neck. So this happens to us day to day, multiple times a day.
So the prior authorization issue is a national issue. And back in 2018, several stakeholders that represented both the providers and the insurers developed this consensus statement. And they recommended that there are 5 areas that would make a meaningful difference if addressed. These stakeholders included not just the American Hospital Association, the American Medical Association, the Pharmacy Association, and the Medical Group Management Association, but as well as the America's Health Insurance Plans and the Blue Cross Blue Shield Association. And they highlighted these 5 areas that could make a meaningful difference. Number 1, selective application of prior auth. A prior authorization program review and volume adjustment, transparency and communication regarding prior auth, continuity of patient care, and automation to improve transparency and efficiency. And so in 2020, the TMA, along with several health plans, medical executives, physicians, came together and we met monthly in an attempt to work together and find solutions to help this process in our state. So we worked together for probably 3 years, and despite all that work, we have not been able to effect any changes. The practices have seen little or no relief. The TMA aims to improve the process by addressing these 5 categories: the clinical validity of the process, continuity of care for patients, transparency and fairness, timely access and administrative efficiency, and alternatives and exceptions. So we want nothing more than to provide the most clinically appropriate treatment for our patients. And so whatever program is instituted has to have some clinical accuracy for us, for the physicians to adhere to this. While a particular drug or therapy may be considered appropriate for a condition, the presence of other illnesses or patient allergy or their socioeconomic circumstances may require a different form of treatment. And failure to account for this then leads to obstruction in proper patient care. So any program that's applied to a service or a drug should be based on accurate and up-to-date clinical information. Many conditions that patients have require ongoing treatment, and it requires that they adhere to treatment so that they can have good outcomes. If you have recurring prior auth requirements, this can lead to disruption in their care delivery and threaten their health. Any unanticipated changes to a formulary throughout the plan year can destabilize them. And if you subject them to new coverage restrictions, disrupts their care. We're suggesting that an approved prior auth should be valid for 1 year from the date received for a chronic illness, and it should be valid for the duration of the prescribed course of treatment. The utilization review needs to be transparent about all coverage and formulary restrictions, and it should be communicated well to the providers. We should have a well-maintained list that we can access on the website, and any changes, we should get reasonable notification prior to that, 45 to 60 days. We're asking that the insurers should make their statistics on denials and approvals publicly available for review. And we're asking that these denials and appeals should be addressed by a licensed physician or provider in the same profession requesting the prior auth. And the provider should be allowed the opportunity for peer-to-peer review when the medical necessity of a requested service is questioned. And then, in order to assure that our patients get prompt care, we need to make these coverage determinations quickly. Once all the necessary information is provided, we're asking that the decision is made and reported to the physician within 48 hours for non-urgent requests, within 24 hours for an urgent request, and within 60 minutes for immediate requests. And we're also asking for standardization for the prior auth process. When you have all this variability, it increases the cost for us on the medical practice side. And if we can standardize, if the health plans can standardize the criteria across the industry, this will reduce our administrative burden. as you know, you saw the performance of Tennessee Oncology. And so when you broadly apply prior authorization programs and and they're imposing significant burdens on all providers, oftentimes these burdens become unjustified, or we perceive them to be unjustified. We're asking the health plans to restrict the management programs to outlier providers whose prescribing or ordering practices vary significantly from that of their peers. But of course, to take the time to adjust for each provider's patient mix and other relevant factors. Health plans should offer practices or providers at least one clinically based alternative to prior auth, such as are not limited to gold carding or preferred provider programs. And what we found in our 3 years of discussion with the health plans, you say gold carding and preferred provider, they don't want to hear it at all. Even though that was the first thing listed in the consensus statement to which all the stakeholders agreed. So thank you so much for your attention.
We're here to answer any questions you may have.
Members, do you have any questions? Representative Freeman, you recognize.
Thank you, Chairman. Thank you for being here and sharing this information. Dr. Schleicher, the work you do saved my wife's life. Members, many of you know that my wife and I had a health scare last year. She was diagnosed with breast cancer. And this was extremely personal to me. These are not numbers. She was one of the people that was denied prior authorization over and over and over again. And the amount of stress that you go through when you receive a denial of an insurance claim and you see a bill for $30, $40, $50, $60,000, when we would wait to go into the infusion lab to get her chemotherapy, directly across the way is the financial aid office. And I might get emotional, but the number of people that I saw that were in tears dealing with a life and death issue, and the insurance company had denied their claim, and they have to go in there and deal with a financial aid office to get the treatment that their family member needs, that then the insurance company ends up approving. And the amount of undue stress. We trust our doctors to make the best medical decisions for us and our loved ones. An insurance company's job is not that. The insurance company job is to figure out how to pay for it. This is something that we should address, and I hope we address here in this committee. Thank you for bringing it up, and I just wanted to put a personal face on this to the members here. Thank you.
Thank you, Representative Freeman.
Thank you, Representative.
Do you have a response?
I'll just say sorry that you had to go through that. I've not been on that side of it, and thank you for sharing that.
Thank you, Representative Freeman, for sharing a personal story. It means a lot, and I'm sure it applies to many of our constituents. Members, do we have other questions? Chairman Terry, you recognize.
Thank you, Chairman. And a couple of points. I just want to see if you have any comments on this. And speaking of the denials, particularly prior authorization or that through TennCare, physicians that are on staff for the insurers, are they required to be licensed in the state of Tennessee? Or are you aware that there are those that are outside of the state?
That is an issue that we have had, is that they are not licensed in the state of Tennessee. I don't know if that applies to TennCare, but I dare say it probably does.
Okay. And Chairman,
You
thank you.
recognize.
And second, have you heard of retroactive denials where a procedure has prior authorization and then the patient goes through surgery, and then after the fact, that there is a denial. And can you speak to that?
So in Tennessee oncology, we do not see that often, but I've heard of other colleagues, especially surgeons, for which that does happen.
Chairman Terry?
Yeah, it does happen, and that's, I will say that that's happened. I'm an anesthesiologist, and we've provided that service on patients that have been, had prior authorization, and then we've paid our staff, and then after the fact, I have no input on the prior authorization, but my payment has been denied after I've paid my staff, so that does happen.
Can
You're recognized.
a challenge outside of the financial challenge of that completely disrupts the trust between the patient and the physician when that happens, which has so many long-term consequences as well.
There is a piece of legislation. It's House Bill 885 by Representative Hawk that will be seen in this committee, I feel certain. And that is one of the issues that bill addresses, is when there is a prior auth that has been given, and it would prohibit you from turning around and then denying payment after the fact.
Any other questions, members? One question that comes to mind is that there was a bill passed in the House of Representatives in the U.S. Congress about prior authorization in September last year. I really cannot find the companion Senate bill to it. Are you aware if there was any movement on that in the Senate?
It did not move in the Senate. I know that CMS is working on rules as it relates to prior authorization for Medicare Advantage plans.
Right.
And if I'm not mistaken, that may include gold carding as well, which was mentioned by Dr. Dixon.
But CMS, well, thank you. CMS moves slow. I understand a rule is being developed that will be effective in 2026. And so that takes a lot of time. And it only applies to Medicare Advantage plans, not generally to the industry. Any other questions, members? Well, seeing none, thank you for coming. We appreciate you drawing attention to an important matter. It really does affect lives. And I think patients who having to wait while they seek approval, yes, and with a serious illness, they do suffer from severe anxiety and stress. Thank you.
Thank you so
everybody
much.
for your time. Thank you.
Our next presentation is by AHP or AHIP. They'll have to tell us what that stands for. Be sure the red light is on and your mic is on, and kindly introduce yourself and
Thank
then tell
you.
us.
Thank you, Chairman, and thank you, members of the committee, for allowing me to spend a few minutes with you this morning. I'm very grateful and feel honored and privileged to spend a couple of minutes with you this morning. America's Health Insurance Plans, AHIP, is the national association that represents our members of all types all across the country. Our members represent national carriers. We represent regional carriers, local carriers, homegrown carriers, carriers that are part of integrated health systems, so they may be part of hospital systems. We help purchasers provide coverage through the employer market, whether that's the fully insured market or helping them through the self-insured market, providing health care in the Medicare market, Medicaid market, partnering with states, and then in the individual market. I am Miranda Motter. I am the Senior Vice President of AHIP. I live in Columbus, Ohio, prior to joining AHIP just before the COVID pandemic. I had the privilege of leading the Ohio Association of Health Plans, so not too far from you. Let me make sure I can. So I'm hoping to take a little bit of a step back today and provide just some basics around what health insurance is, sort of the nuts and bolts. So what is health insurance? Who regulates it? What is regulated? And where do most Americans get their health care today? I know I'm sitting before a very sophisticated group of members, so I know you all know a lot of this, but I thought it's always good to sort of take a step back and talk about some of the terms in health insurance and really some of the relationships in health insurance that are really so key as policymakers are looking at legislation and bills and how that may impact your communities and the businesses and that are in your communities, and certainly the state Medicaid program for all the patients that it serves. I want to spend a couple of minutes on looking at the healthcare premium dollar. We think it's really important that policymakers and stakeholders understand where their premium dollar is going by types of service. And then spend a couple of minutes focusing on, as we have looked at that premium dollar and where that spend is going, really trying to improve competition in certain markets where we see the highest piece of that spend for purchasers of healthcare. So the employers in your communities, the patients in your communities that are trying to afford healthcare. And then lastly, spend a couple of minutes on some examples of some of the tools that health insurers are using today. These tools are tools that we are using because we are being demanded to bring innovative solutions to the table, whether it's by our employer purchasers or whether it's by state Medicaid agencies or whether it's by the federal government and the Medicare program. As I said, who AHIP is, who we represent, I would say that the diversity of our memberships, we really believe brings value in that policy making and the policy development best practices discussion. We believe that is unique. So let's talk about what health insurance is. There is a lot of content on this slide. I will tell you there are a number of slides, I think upwards of 20 slides. I'm only going to spend some time on a few of these slides, so really hoping that most of the information in here can be a good resource, and if we can provide any follow-up information, we're happy to do so. So as it relates to this slide, there are really three key takeaways that I'd really like to leave you with on this slide. First, health insurance helps individuals access healthcare. I think many of us would say, but for health insurance, the cost of going in and getting a service in healthcare is unaffordable for many of us. And so we rely upon health insurance to help us afford the underlying cost of care that we need. Second, if health insurance costs are going up, it's a reflection that the underlying cost of care is going up. I like to say that that health insurance is a reflection of what it costs to actually purchase that health care. And so again, if we're seeing health insurance costs go up, we really need to take a step back and look at the underlying cost of care and bring some solutions to the table to address those underlying cost of care. And I will do that here in a few minutes. How does it work? A couple of just real simple, quick concepts. Individuals that purchase healthcare become part of a risk pool. And that risk we're able to spread over a larger group of individuals to help that access and that affordability. And essentially, health insurance providers, health plans partner with providers who agree to certain standards, to certain qualities, and agree to charge a patient and a purchaser of healthcare, whether that's the employer or the state, a certain price in exchange for being able to serve patients, being able to serve large volumes of patients from the insurer. So that's the essential basic agreement. And understanding that both of those things are so important as you look at the risk and how insurance works. The value of health insurance providers, again, here, just focus on a couple of things, delivering financial peace of mind, as I said, but for health insurance, many of us would not be able to access healthcare. It doesn't matter how good the healthcare may be in your state. If you can't afford it, you don't have access to it. Negotiating lower prices, whether that's from doctors, providers, pharmaceutical companies, to actually get that lower price for that purchaser of healthcare. And then the other thing that I would like to mention, the last bullet here, is health insurers have a 360-degree view of of the patient. And that also becomes incredibly important, particularly when you're thinking about a patient that may have medical needs, that may have behavioral health needs, that may have pharmaceutical needs. Being able to visualize and see all of that is really important as you're trying to determine the right care and the right time and the right place for that patient. A couple of key terms, I know you have all seen these before. Health insurance helps Americans pay some or all of the cost of their medical services. Premiums are your monthly fee that you pay. And then the bullets that you see, the deductible, the copayment, coinsurance, those all are what make up the patient's cost sharing obligation, right? And the visual that I like to talk about, particularly when you're thinking about the relationship between premiums and cost sharing, is a really important one, particularly as policymakers, as you look at bills and legislation that stand. So, as I said, as health insurance costs increase, it's a reflection of the underlying cost of care increasing. And as many of you know, I'm sure you've heard from your employers in your community, individuals in your community, the state Medicaid department in your communities, that cost is increasing. And as that cost is increasing, individuals, employers are making hard decisions about how to make sure they can continue to afford health care. So for the employer in your community wanting to make sure that they can continue to afford health care for their employees, as they look at their options, sometimes they need to make a decision about selecting coverage where the premium may be lower because the employer may be paying more of that premium. And as a result, because of this relationship, that product will have a higher deductible. The reverse is same. If an employer or an individual is looking for a healthcare coverage where the deductible or the cost sharing component is lower, their monthly premium is going to be higher. So let's think about an example. I know one of the things that we talk to legislators a lot about is copay caps. When you're thinking about policy measures that may include a copay cap, that is on the right-hand side of what this teeter-totter looks like. So if you're capping what that amounts, what the impact of that is going to be from a financial actuarial perspective is that the premiums have to go up. These things have to balance one another. Health insurance is very highly regulated. It's highly regulated at both the federal level and, as you all know, at the state level. With respect to the state level, state regulators look at licensing, financial solvency, rates to make sure that the price is what it should be. At the federal level, depending upon what the type of coverage is, so employers that self-insure, they are governed at the federal level through ERISA. And there is a reason for that uniformity that provides affordability for employers, again, continuing to try to provide health insurance to their employees. In the Medicare space, certainly the federal government regulates the Medicare market, and then we see some regulation in other areas that impacts health insurance, whether it's through HIPAA or other types of federal regulation. So what exactly is regulated? Many things within health insurance is regulated. So rates, which is essentially the price of what the healthcare coverage is, we're regulated by what the product looks like. Provider networks, the administrative costs, including profit, financial solvency, I mentioned, company licensing, I mentioned, consumer complaints, which the Department of Insurance all across the country regulate, agent broker actions, and more. So let me spend just a couple of minutes talking about price. Health insurers are the only entity in the entire healthcare delivery system where our price is regulated. Our prices have to be actuarially sound. And what does that mean? That essentially means that they have to be justified in terms of what the coverage looks like. So medical costs, right, there is this balance between expenses have to reflect what the price is going to be. I like to say that it is like a shopping cart, right? If you want to purchase a certain kind of service, that service at the end of the day has to be paid for, and ultimately it's borne by the individual or the employer of healthcare. Health insurance prices are regulated both at the front end and at the back end. This is the bookend concept, right? So our rates, departments of insurance look at the rates at the front end to make sure that they are actuarially justified, that they can pay for the claims that that coverage indicates, and then on the back end, relative to a medical loss ratio. So if that price wasn't right on the front end and there wasn't enough spend as it relates to the medical claims, policy holders are rebated that amount. And you'll see that here on the next slide with a further description about what that medical loss ratio needs to be in the large group market and the small group market. Again, health insurers are the only entity in that entire system where our administrative costs, our medical costs, and importantly, our profits are regulated at that federal level. Networks, I mentioned that insurers have both federal and state regulations as it relates to their networks to make sure that the patients have the right care at the right time at the right place. There's lots of innovations that are taking place right now. We saw a lot of that during COVID with telehealth and making sure that individuals have access to 24/7 care. There's access to care through 24/7 nurse lines, through web-based apps, non-traditional sites of care, wanting to make sure that the care is received in an accessible way, in a safe way, and the most affordable way for the patient. I'm not going to spend a lot of time here, but these are the different markets. I know you're very well aware in terms of the numbers that are served in Medicare, the numbers that are served in Medicaid. I would just note one thing, as many of you probably know, as we bump up against the end of the public health emergency, but with the decoupling of the continuity of care requirements that were part of Medicaid programs, individuals in Medicaid will now begin to be redetermined. And so you may see some shifts in the market. And I say that for a couple of reasons. You may see that in your employer community where patients may be gaining access to employer coverage. And then from a provider perspective, we've also been spending a lot of time with our provider partners talking to them about Medicaid redeterminations because of the fact that as individuals become redetermined under Medicaid and they may be deemed ineligible, those providers may not have a reimbursement source. So it's so important to make sure that those individuals have access to care somewhere else. The individual market and certainly the supplemental health insurance market. Where do most Americans get their health insurance coverage? Most Americans still today get their health insurance coverage through their employer. It is employer-based. Employers, again, in your communities all across the states are providing healthcare to their employees, and they are making very difficult decisions, as we know, as the cost of care increases, about how they can continue to provide health insurance to their employees. I would say a couple of things. What we're seeing at the national level, again, as employers are trying to make these hard decisions, health insurance, health care is one of their top line budget spend items. We're seeing a couple of things. One, we're seeing employers begin to self-insure. They're moving to the self-insured market. And one reason for that is because they're able to create coverage and a plan that best suits the needs of their employees, and they may not have to adhere to some of the mandate requirements. And so it's really an affordability issue. I've put some of the Tennessee numbers up here, and you can see the self-insured market here in Tennessee. So while 46% of Tennesseans get their coverage through their employer, as you look at that coverage, 60% of that 46% is from an employer that has decided to take on the risk themselves. Where does the health insurance premium dollar go? This is information that we believe is super important for policymakers, for stakeholders to understand as we look at policy solutions to drive down the underlying cost of care. You'll see here 22.2 cents of every premium dollar goes to pharmacy spend. And the next big bucket of spend happens in the hospitals. It happens in outpatient hospital costs and in emergency room costs. So as we look at those two buckets, those are the biggest areas of spend. And as a result, we spent about a year laser focused on these two areas and how can we restore competition in, quite frankly, some broken markets that have resulted, particularly in the pharmaceutical market. And I can share more of this information, but we put together 10 recommendations that policymakers can look at as it relates to continuing to make sure that your residents of your state, that patients, that employers can continue to access care in a way that's most affordable for them. Providers are driving innovation through value-based care, through work in the privacy market and telehealth. I mentioned that earlier. I do want to spend just a quick second on value-based care, paying for quality. This is an area where we are seeing a movement in moving away from the traditional volume-based care to value-based care. And I raise this because this is a place that employers are demanding this of insurers, states are demanding this of insurers, whether it's in the Medicaid space and the Medicare market. So really looking at what is the value of that premium dollar. I won't spend a lot of time on this, but what is important here is as you look at that value equation and those value frameworks in the health insurance, and as we partner with our healthcare providers in this space, as you move from a traditional fee-for-service across to a value, you're able to eliminate some of those, as what we heard the medical society talk about, some of those utilization management or some of those prior authorization components. So as providers take on more risk for the services that they perform for the patients, they are able to eliminate some of those utilization management, prior auth being one of those examples. Prior authorization protects patients. It does provide financial protection. One of the things that I think as we think about prior authorization and wanting to make sure that that is also a place for the patient to understand whether or not the service that their provider is requesting is covered under the plan that their employer has purchased for them. So it really gives them information about whether that service is going to be covered, and then it provides this patient care. It does identify overuse, misuse, and safety issues before that provider delivers that care. The value is well documented. There are a lot of statistics on this page. I am not going to go through all of them, but I would say under unnecessary care, 65% of physicians reported that at least 15 to 30% of the medical care is unnecessary. 15 to 30% as reported by 65% of physicians. That is still a significant number. The most common reasons for denial is incomplete information. So the information that the provider has provided isn't complete. And the next reason is it does not align with evidence-based practices. The one other thing I would like to mention here before I move to real quick to clinically administered drugs is to mention two things. One, I talked about value-based care at one end of the spectrum in terms of eliminating some of these issues. The other end of that spectrum is moving to electronic prior authorization. I know the Medical Society talked about the 2018 consensus statement that we worked on hand in glove with the providers. We really believe that as health insurers, we have demonstrated some clear action steps that we have taken to deliver on that consensus statement. One area is we spent a lot of time working with providers around electronic prior authorization. 60% of providers today still submit prior authorizations manually. That manual submission has a real impact on how that submission runs through and how quick that provider is able to deliver care to their patient. Moving to electronic prior authorization with support and help from plans is a huge opportunity. And it is one opportunity, Chair. I know that you mentioned the House bill that is part of the conversations that's happening at the national level, is to move to an electronic system, not only for those prior authorizations, but to also make sure that we've got interoperable systems that talk to one another so that we can make sure that that patient is getting the right care at the right time. Medical systems are talking to pharmacy systems and et cetera. Let me talk just a quick minute then about clinically administered drugs. This is another area where employers, as they look at their top line spend in their health insurance budget, health care budget, specialty drugs is becoming their number one item of spend. We know that more and more specialty drugs are coming to market. The price of those specialty drugs is increasing. I don't think it's hard to open a newspaper. I still read a newspaper, an article, and not see a new price, a new launch price, a new increase price. And that's what employers are struggling with today. As they have struggled with this, they have asked for insurers to bring innovative solutions to the table. And one of those solutions is relative to clinically administered drugs. So these are drugs that the patient cannot administer themselves, but they have to go to a clinic, a physician's office to get that drug administered. The innovation that plans have brought to that table is to use the same specialty pharmacy, in many cases that a hospital may be using, that physician's office may be using, to provide that same drug through the same specialty pharmacy at a safe way for that patient at a more affordable price. So whether it's that patient and that employer, so that they can continue to provide health care for their employees. We recently released a study that would actually demonstrate what that markup looked like. We felt like it was really important to have data around the differences in price that employers are experiencing as it relates to being able to utilize a specialty pharmacy and send that drug to the hospital. The same drug using the same chain, making sure it's in a very safe way for that patient. And you can see here, we looked at 10 different physician administered drugs, and on average, hospitals charge double for that same drug. And on average, physicians' offices charge 22%. So we're talking double and 22% that patient and that employer is having to cover. The same drug through the same specialty pharmacy in many cases, the same safety protocols to make sure that that patient can afford that drug. Again, here's some data so you can see the differences in price.
Ms. Marder, I just want to remind you that in the interest of time, we do have another presentation. So kindly wrap it up.
Absolutely. I
Thank
will
you.
wrap it up. And I think I just have, apologize, Chair, one more graph that just slices the data another way so that you can see the differences in those 10 drugs, in the cost, and the solutions that we are bringing to the table, and happy to answer any questions.
Members, do we have questions? Representative Hammer, you're recognized.
Thank you, Mr. Chairman. You mentioned the EPA and the processes that you're going to be going through right here.
Sorry.
I was just curious, what is the update from the industry perspective with the fire standards and the kind of the overall industry preparations for putting together a standardization of data that'll make it easier for providers as well as insurers to do these processes?
Absolutely, Chairman and a Representative, thank you for that question. So the work to bring electronic platforms to the table, is that for the prior authorization?
It was more along the fire. I can't remember what exactly, FHIR. It's a standardization that's a data standardization project that's been arranged by, might be better for the next guest to talk through, but I was just curious. I know AHIP as well as the medical associations and everybody have been trying to get together on correct standardization. So
Yeah.
it kind of helps reduce some of this
Yes.
administrative burdens and makes the process more efficiently done. So
Yes,
if
Chairman
you
and
don't know.
Representative. So uniformity of prior authorization across.
Yeah,
Yeah.
and if you don't know, you
Yeah,
can, we can
sorry.
touch base or the next presentation
I'll
can,
leave that to Dr.
can address it. Thank you.
Chairman Lafferty, you're recognized.
Thank you, Chairman. You had a slide in there that talked about the number of employers that are starting to self-insure.
Mhm.
Excuse me. Is that trend nationally also, or is that just something that you had for Tennessee? Do you know if it's a trend nationally?
Ms. Mar.
Chairman and Representative, that is a trend we are seeing all across the country in terms of the number of employers that are self-insuring, beginning to self-insure. You know, you used to traditionally see really large employers self-insure. And what we're seeing is certainly more smaller employers beginning to self-insure, again, as they try to manage the cost.
Thank you, Chairman.
Representative Ritchie, you're recognized.
Thank you, Miranda. One of the slides that you mentioned in there, and it goes back to the previous presentation, is on the prior authorization. 60% of the providers are still submitting the authorization manually.
Mhm.
Do we know the data between the electronic and manual as far as for the efficiency, as far as for the turnaround time for getting that back?
Yes. So Chairman and Representative, yes, there is tremendous advantage when providers utilize electronic systems. They're not only able to get the information back quickly, they're able to deliver that care to their patient quicker. Yes, there are really good data, and we can provide you. Last year, we did release a survey that we did. It was called our Fast Path survey, where we actually looked at and partnered closely with a number of physicians and physicians' offices, and they, utilized their electronic systems, and they found a real meaningful difference in terms of both their own administrative burden, the amount of internal resources that you heard the medical association, the society talk a lot about, but then certainly making sure that the patient is getting that care too. So I can share that with you. I can share it through the chair's office.
Chairman Spicky, you're recognized. Thank you. Any other questions? Oh, Representative Sparks or Chairman Sparks, you're recognized, sir.
Thank you, ma'am, for your testimony. Would reference-based pricing be one of those models to help lower cost?
Chairman and Representative, yes, that is something that employers are looking at, reference-based pricing. So again, it gets at this concept to give them some predictability in what their healthcare costs are going to be.
Yes.
So that is one of the many approaches, along with value-based frameworks, et cetera, that employers are really looking at.
Yes. I mentioned last week in committee about Mark Cuban's Cost Plus RX company. It's kind of disrupting the marketplace, which I think is a good thing. I think most people know healthcare costs are rising. I think America, we pay the highest premiums on any country on the face of the earth, 40% more on average than other countries. Something's apparently wrong. Bob mentioned, or Representative Freeman mentioned earlier, his wife's situation. My heart goes out to him. I'll be real quick, Chairman. I've got a sister that sold insurance, #1 insurance agent for who she worked for. She got struck down with a brain tumor. I reached out. She was on life support and luckily come off life support. And Stonecrest TriStar was really good to her. But when I reached out to the insurance company, I won't say the name of the insurance company, they kept telling me she had coverage, 120 days worth of skilled nursing coverage, only for the nursing home to be denied. And I tell you what got their attention when I brought Fox 17 up here. Thank you, Stacey K, Scott Couch. When they came in, that got their attention. That's the only time I got a call from the insurance company. So like Representative Freeman felt pain, I felt pain. I try not to let that skew how I see things, but I just want to thank the chairman for the discussion of healthcare costs that we've all been touched by. But I remember testimony from, I think it's Dr. Lawrence Van Horn from Vanderbilt School of Management. I really liked his testimony. I think we should have more of this discussion, Chairman, committee. Love to see Dr. Van Horn to come up, talk about the economics of healthcare, which I think would lower cost. Something's wrong with our system. I think we all know it. We just need to have more discussion about it. Thank you. Thank you, Chairman.
Thank you, Chairman Sparks. Chairman Rudder, you're recognized.
Hi there. I want to talk with you about white bagging. It says here that specialty pharmacy ships a patient's prescription directly to the provider, the hospital or the physician's office, where it's held until the patient arrives for the administration of the medication. What happens in the event that when the patient arrives, something has changed? There's a weight loss, there's blood issues, whatever that may be. What happens to that formula that has been mixed and shipped directly to the hospital for that patient for that day? What happens to that patient and the medication that they should receive that day if the medication no longer fits the issue that the parent, that because of the issue that the patient's having that day, they're no longer able to receive that medication? What happens?
Ms. Potter?
Chairman, thank you for that question. That's a great question. So let me say first and foremost, employers and purchasers of healthcare, and then certainly insurers, only use this if it's safe for the patient, if it's the right care for that patient. So that is at the outset as you look at these kind of programs and the types of patients that they're used for. As it relates to your specific question about what happens if a patient gets to a hospital and the dose has changed or the drug needs to be changed. Most insurers, if not all of them, have exception processes. So when that patient gets to that facility and that drug is no longer right for that patient, the hospital most times can use a drug off of their own shelf to provide that patient. So there are exceptions. There are systems that are built in place to make sure, again, that that patient gets the right care, the care that they need, at the right, in all of those ways, in the most affordable way for that patient. So though there are many exception processes that exist that would address that specific issue.
Are we talking real-time issues, real-time exceptions, so that the patient would not have to go home and come back another day? You're saying that this formula, there is another formula that could be maybe mixed or whatever in the hospital pharmacy to deal with that patient's specific needs on that day, and that patient would not have to go home and come back when they're fighting for their life.
So there are exception processes that exist to make sure that that patient's care is not jeopardized, right? So again, when we can follow back up in terms of the specific exemptions for the plans that exist here in the state, but there are approaches that are in place to make sure that that patient gets the care that they need when they need it. It is in our best interest. That is what we want to make sure happens, is that that patient, that individual that is also our member, gets the care that they need.
Well, I'm glad to hear you say that there are exceptions, but the paramount issue here is that it is in the patient's best interest that we get the right drug to them in a timely fashion. As my colleague had spoken about his wife and the trials that they've been through with breast cancer, I went through the same thing last year with my husband and chemo. Thankfully, he never had to face that, but he saw a lot of people in the situation that did have to face that during his journey through this journey to save his life. So I'm glad to hear there are exceptions, but I think it always should fall with the best interest of the patient and making sure their lives are saved, not saving money on the insurance side of this. We need to make sure that those patients have what they need on the day that they arrive for their medication.
Oh,
Absolutely.
thank you. Thank you, Chairman Rudder, for sharing this. As it shows, so many of members whose lives have been touched and their families have been touched. So healthcare from that point of view is very important. And the role that pre-authorization or other processes play sometimes in delaying and compromising care, that is our concern. And hopefully we can come up with better solutions and take care of those things. Members, in the interest of time, we need to move on to our third presentations. We don't mean to be that unfair to them. Their time has been cut short, but that's the hazard of being number 3 on any list. We have members from Evicor. Kindly introduce yourself.
Yes, thank you for the time and the invitation, and I will try to be focused because I know we've had a long presentation. So Chairman, thanks for the invitation. I'm Eric Gracious. I'm Chief Medical Officer at Evicor. I am a pediatric oncologist, and I practiced in Chattanooga, Tennessee before joining the company. And so I'm intimately familiar with a lot of these topics, not just nationally, but also here in the state of Tennessee. And I want to just take a minute you've heard a lot of really long presentations. First you hear from the Medical Association, and they have a very specific story that they are telling. And you hear from AHIP, and they have an also equally specific story. So what? Okay, why do you care? Why does this group need to care about this? And it's because this is an issue that's complicated. It's an issue that the provider community and the payer community have not been able to solve together. So it's bubbling up, and it's affecting people's lives. I think you've heard from both sides, and I hope you can take them at their word that having worked on both sides for many years, I'm in a relatively unique position. I know we have several physicians here among the representatives, and so I know you all live this as well. I don't know how many of you have actually worked for the health plan side and seen the macro level and seen the harm that comes to patients when inappropriate care is delivered. There's an unavoidable truth in this country, in that it is that we spend the most on healthcare of anybody on the planet, and we have the worst healthcare outcomes of any developed country. So the concept that we can just kind of look the other way and the existing system is going to get it right, it's flawed. It's not. It's just the data says that's not true. We owe our patients, we owe our members, we owe our citizens better. So taking a system and throwing it out, that's not the right approach. I have some slides presented. I think I'm going to, in the interest of time, I'm not going to walk through those. I'll leave this as a leave behind for you because I think it's more important that I'll leave time for questions here and some dialogue. What I hear in the Tennessee Medical Association's presentation is a really specific view of the data. One of the things I don't hear in there is all of the processes that occur where redirections of care approved. There's a lot of reporting on the end state of denials. There's not a lot of reporting on, oh, well, maybe you could do this instead. Oh, yeah, you're right. I'm good with that. That happens at a very high percentage every day. And some of our service lines, that happens at a much higher frequency than denials do, because the nature of the waste in certain services isn't providing care that when none is necessary, it's providing the wrong care, and a different plan is better. And what a lot of folks don't appreciate is that sometimes the better plan is something that's more complex or more expensive than what's being originally proposed, because it's something the patient's going to need anyway. One of my early jobs, I understood the complexity of this really, really early in my transition from direct patient care to working in medical benefit management, because one of my early jobs was to help to pull together a resource around something that was very personal to me, which was the best way to do advanced imaging in children with cancer. That was a resource that didn't exist. There wasn't a commercial guideline. There wasn't a specialty society saying, here's how to do it. And we needed to understand it better. So pulling together this evidence, and I thought this was going to be very simple for me because I did this all day, every day. And what I found was that I had huge blind spots that had crept into my knowledge. One of the slides I'm just going to show you really quickly here is, why is this a problem? Okay, one of the things is medical knowledge is doubling at an incrementally faster rate. So the concept that any physician anywhere can keep up with across the breadth of their practice, even in a specialized setting, is a complete fallacy. Blind spots creep into your knowledge and you fill them, and then there are different ones every day. Medicine has been a team sport for decades, is now a team sport more than ever. And it requires everybody working together to make sure that for each patient, we are delivering the best possible care in the best possible setting, where appropriate to consider cost at the most affordable cost when all other factors are equal. But this is a collaborative, ongoing effort, and we hear a lot about prior authorization being blamed for delays in care, and I want to talk a minute about some of the delays in care that are removed by prior authorization. And again, back to my specific example from my practice, one of the things that I saw really commonly is in my brain tumor patients, which were my second most common diagnosis category. Those children, particularly the younger ones, tended to come to me sicker and in worse shape than many of my other cancer diagnoses. And there's a lot of reasons for that. They're hard to diagnose and they masquerade as other things. But one of the things I focused on that was used to frustrate me so much in practice was that patients were getting the wrong imaging. And they were bouncing around. It's like, oh, they're little. I don't want to sedate them for their MRI. And it's going to be a hassle to get the prior auth. So, and maybe it's nothing. So I'll just get an x-ray or I'll get an ultrasound. And there were sometimes weeks and weeks and weeks of delay. And so one of the things in pulling this together, we have really clear guidance from multiple specialty societies that a new headache in a young child is always a cause to do imaging. And that in the overwhelming majority of those kids, the study that they need is an MRI, with some specific exceptions. So that's what I wrote into the guidelines. And one of the things that we do really commonly is somebody will come in and say, hey, I want to do, this was a perfect example. The pediatrician requested a CT scan. We have a very efficient process that steers, can communicate that back and say, well, the evidence doesn't support a CT. The evidence does support an MRI. Would you like to change your request? And if the physician says, yeah, I actually like that better, great. That's done in the moment. There's no additional work required. That's a really common technique that's used today. And very shortly after I got these guidelines out there, I was on a peer-to-peer phone call and this pediatrician was just ripping into me. I didn't barely get my name out and he's yelling and screaming. And I let him kind of wind down and I said, can I interject for a minute? I think there's been a miscommunication of what's going on. He goes, there's no miscommunication. You denied my CT scan. I said, yes, I did. I said, but did your office not tell you what we offered was an MRI instead? And he stopped and he said, you'll give me an MRI? I said, sure. So, because if you get a CT scan and you don't see anything, what are you going to do? He says, well, I'm going to need to get an MRI. I said, exactly. And if you get a CT scan and you do see something, what are you going to do? He goes, well, it's not going to be detailed enough, so I'm going to, So yes, I know it's a little bit more of a pain, but it's what the child needs, and you're saving this child weeks of delays in care and getting sicker. That kind of interaction happens dozens of times every single day at our one company. So while there are delays from the administrative process, there are also delays in care that are saved. Patients' health is improved, their care quality is improved through this process. So I think the opportunity we have before us is to focus on what can we do to what are some of the underlying problems that are potentially solvable through legislation? Where can we raise standards to a level that everyone can agree to that need to happen? I've been doing this in a lot of states around the country, and there's gross misperceptions about what the standards are. The cases, it makes me cringe to hear the cases presented by Dr. Schleicher, because a 50 delay, 3-week delay in a standard generic drug. I can honestly tell you, if that had happened at my company, I would have been looking for some explanation, because that shouldn't have happened. If that information is exchanged quickly, those examples would have been approved instantly in under 3 minutes with a web-based utilization. To Representative Hemmer's earlier question, the average time saved in an electronic prior auth versus a manual one is about 2/3 of the time is saved. So it varies from service to service, but and this is an area that we're focusing on. I want to address gold carding head on, since Dr. Dixon brought it up. The reason health plans just kind of cringe when they look at gold carding is because gold carding is based on a flawed premise. And it's based on the premise that if you look at a physician and their ordering behavior on a specific service one time and they're good, you can just look away and they're good. They're always going to stay that way. There's a lot of reasons why it fails, and I don't we've already had some long presentations, so I'm not going to go through all of those here for you, but suffice it to say, what usually happens when a gold card is placed, and just for that reason, within 12 months, the ordering behavior changes to what it was before there was oversight in place. There's multiple references from that around the globe. The other piece is I've been talking about this in other states. I tend to view this as a physician. I think about it as quality, as adherence, and we're focused on these high percentage rates. And it wasn't until I was talking to a legislator in another state whose state was considering this, and this person is not a clinician, but there's, like many of you here, not clinicians, but sophisticated consumers with personal beliefs and personal experiences. She said, I'm familiar with this concept. She goes, and I don't like it. I said, okay. She goes, what it sounds like to me is our medical association is trying to tell me that they can mess up 10% of their care decisions, and I don't get to care about that as a legislator. And frankly, that was a bit shocking for me to hear. I had never thought about it from the patient's perspective and what these statistics are when you flip them on their head. 90%, 95% sounds like a great score if you're taking an algebra test. It's an A grade. But show me any clinical environment, any healthcare setting where even a 5 to 10% error rate would be considered acceptable, let alone this 20% number that's being proposed by TMA as an exception. I would be embarrassed as a physician to sign up on that. So, I mean, there's some real opportunity here, and I really just hope that we can work through it without getting stuck on practices that we know don't work, that we know are outdated, and we know put patients in harm's way. Because at the end of the day, to Representative Rutter's point, this is all about the patient. This is all about what's right for the individual patient, and we have to come together. We have to think about it as a team, and we have to shelve our prejudices and our history in the way we've always done it, because the way we've always done it has gotten us here from all parties. So I thank the group for bringing it forward, being willing to consider it. I think there's a lot of work to do on the proposed bill to get it forward. But I think we're one of several parties who have all taken the time to be here today, who I think are willing participants to collaborate and compromise and see what we can do if we're specific about the problems we're trying to solve. And I'll stop there and answer questions.
Well, thank you. Thank you for accommodating us for time. And just to keep your testimony in perspective, kindly tell us, what does EviCore do?
Thank you, sir. I was, in my attempt to be brief, I jumped over that initial component. EviCore is it's the largest medical benefit manager in the country and the largest employer in Williamson County here. We manage medical benefits for over 100 health plans, including the majority of the health plans in the state of Tennessee.
So you provide pre-authorizations?
Yes, among other things, but that's the biggest chunk of our utilization management work is done through prior authorization.
And just to simplify for everybody, gold carding means this is a Texas model in which if a physician or a practice during the previous year were correct in 80% of the time, their request for pre-authorization was approved and they were right. So for the following year, they get a pass that they don't have to seek pre-authorization. Is that correct?
Yes, that's basically the concept. Texas, the bar is actually 90.
Okay. So you're right. 10 to 20% is a significant number. Members, do we have questions? Starting with Representative Hemmer.
Thank you, Mr. Chairman. Dr. Gracious is a proof that you always want to be nice to everyone because he's a former colleague of mine. And one day you may be on the other side of a microphone from him. But thank you for coming today, and I appreciate you and the rest of the presentations brought about today. And I know this is such a tricky problem for all of us to look into. I've been on it both sides of the coin and being involved on the health insurance industry, but also being a patient that quite frankly, I remember literally crying in the mailbox getting a approval from this for my cancer treatment. So I know it affects everyone, but I really do feel like we're at a precipice point for this industry where, as the chairman mentioned, CMS is really starting to look at things, putting forth actual standards for the Medicare Advantage, which will help, I believe, trickle down to the other lines of business and create, standards for the industry, as well as some of the work that's being done from the provider side, as well as is seeking to reduce the administrative burden that everyone knows does exist. So my hope is this is something that gets better for everyone in the industry. Thank you.
Thank you. I don't see any other questions, but
So,
in retrospect, just to give us a balance, how do you balance the need for controlling costs without getting into literally rationing care?
It's a great question, and Chairman Kumar, I'm going to answer that, but I also want to take the chance to follow up on a question you asked on for the previous presenter around the status of the Improving Timely Access to Seniors Act at the federal level. That's that's the bill you referenced that went through the House and hadn't moved in the Senate. What happened in the interim is shortly after the House approved it, the Congressional Budget Office assigned a score of $16 billion in federal cost over 10 years, and that caused the bill to have some pause for some reconsideration. I will say that's a bill that had been tracked a long time. It had pretty broad support from really not just AHIP, but also the AMA and the American Hospital Association. And there were some elements introduced at the last minute at the committee level that I think skunked the bill a little bit from a cost perspective. And that's where that one's bound up. But again, I think for me, Chairman Kumar, to answer your question more directly, it goes back to, again, it's what I said before, and Chairman Rutter raised as well as Representative Freeman, Representative Hemmer, all the personal stories. We got to stay focused on the patient, okay? Because the insurance company's job is to make sure payment is available for services that are necessary. And if we start with focusing on making sure the patient gets the services that are appropriate and necessary, the rest kind of follows. Our specific approach to this is not cost isn't the primary consideration. It's really targeting the example I gave. It's the right care, and you have to take a longer view on the total cost of care and the total health of the member over time. And by doing the right thing first, a lot of those other dominoes fall, but you can't be so focused on the individual decision around cost. You've got to take a larger view. So I think, the regulated insurance industry has to hold costs within certain parameters, and there's a lot of buckets that they have to sit in. And I think the one where prior authorization helps to fill that gap today is that appropriateness component. And that said, Representative Hemmer said it exactly right. We're at a tipping point. Maybe we passed a tipping point a couple years ago. Maybe without the pandemic, we'd a little further along from a policy perspective than we are right now, because that's when this work started. But the other piece I would throw in there, I think there is something to the value-based care opportunity, although that's not a magic bullet, because in some ways that's shifting the responsibility for doing this work from the health plan to the provider. And I think it's an important conversation. And what I've seen is that many of the payers, when a provider is engaging, and particularly when they're taking downside risk, they're offered opportunities, clinical alternatives to these waivers, just like what was proposed by Dr. Dixon. And what I've also seen is that as we work with some of our clients are actually risk-bearing provider groups. They're not health plans. They're hospital systems, they're ACOs who have been offered the choice and said, you know what, I recognize this area that I'm working in that I need help with is not an infrastructure I have in my practice. It's not something I want to add to my practice. I need you to do that. And it's really been an eye-opening dynamic for me personally over the last couple of years. And with those particular engagements, we're doing, in a lot of times, exactly the same work and service that we're doing on behalf of the payer. But the frustration and from the provider groups are almost non-existent. And it's the same work, but we're there in partnership. We're there at their behest. So again, it speaks to my earlier point. I think the opportunity here is to think about better and more collegial and different ways to work together across the groups. I think that's maybe a path forward.
Thank you. I need to give the closing remark to Chairman Spicky. Well, thank you. Members, any other questions? Otherwise, we'll go back into session. And if there is no other business and without objection, we stand adjourned.
We'll get started. Welcome and good afternoon. Today is Tuesday, February 14th. I hereby call the Insurance Subcommittee to order. Madam Secretary, please call the roll.
Representatives Capley, Sapicki, Himmer, Hicks, Kumar, Lafferty, Martin, Mitchell, Rudd, Rudder, Terry, Chairman Haynes, you have a
Here.
quorum.
Thank you. Before we get started, are there any personal orders? Seeing none, we have 7 bills on the calendar this week. First is item number 1, House Bill 1215 by Chairman Rudd. We have a proper motion and second. Chairman, you're recognized on the bill.
Thank you. I'll start to say good morning, good afternoon, I guess. We're about there. Madam Chairman and members, I'm here to present to you HB 1215 on behalf of Speaker Sexton. The legislation is known as the Managed Care Organization MCO Reform Bill. It's being introduced to reflect and protect the values of Tennesseans. The purpose of this bill is to prevent an MCO contracted with the Bureau of TennCare from covering a medical procedure performed anywhere in the country for the purpose of artificially changing a person's sex. Tennessee taxpayer dollars should not be used for such procedures. The bill prohibits an MCO, from which currently there are 3, from contracting with TennCare covering transgender medical procedures and reimbursing them for transgender medical procedures through the following: through the Bureau of TennCare, any private healthcare organization regulated by the state, any local or state insurance program of the MCO, any MCO operating in Tennessee and regulated by another state. A TennCare MCO may not offer transgender surgeries anywhere in the United States if they are contracted with an MCO and TennCare. This bill does not discourage or prohibit counseling. In closing, if the MCO covers transgender procedures within 90 days of the effective date of the violation, the MCO must come into compliance. If the MCO does not come into compliance within that 90 days, it is no longer eligible to provide medical assistance pursuant to this part. That's the bill.
Thank you. Do we have any questions from members? Chairman Sapicki, you're recognized.
Thank you, Madam Chairman. A couple questions. This only applies to the MCOs currently in Tennessee, is that correct?
Yes.
Chairman.
Does this prohibit any other healthcare providers from providing this care for their people coverage as long as they're not an MCO, is that correct?
As currently written, that's correct.
Okay. And so there are other healthcare options for people who do want to pursue this. If the MCOs stay in compliance with this law, there's other avenues for those people to explore. Is that correct?
Both in the state and out of state.
Thank you. Thank you, Mr. Chairman.
Representative Mitchell, you're recognized.
Yeah, thank you, Madam Chair. I've got just a couple of questions for the staff attorney. I'm just wondering how this legislation would affect the 14th Amendment, equal protection under the law, as well as the Commerce Clause.
We'll go out of session and hear from Matt Mundy.
Matt Mundy from Legal. I don't believe that, at least in my reading of it, that I believe that there's an equal protection issue in terms of differentiating between classes. But if there were to be, I would suspect that there's arguments to be made on both sides as to whether the state's interest is sufficient to overcome a challenge based on the 14th Amendment. I think that it would be difficult for me to take a position on something that would be a question of first impression, I think, in Tennessee. And your second was the Commerce Clause.
Yeah.
I'd considered that issue. I don't think that I think it would be the Dormant Commerce Clause. Maybe it would be a potential issue. But in going through the analysis, I think that the state's interest in regulating this particular area would probably be sufficient to overcome that challenge as well.
We are back in session. Representative Mitchell, you're recognized.
Well, that's interesting that we can, control what an MCO does in other states. So that's great concept. I guess we may need to look at other laws. Thanks.
Chairman Rudd.
This does not control what they do in other states. It simply states that a MCO that's providing this service in other states can't have a contract here.
Thank you. Any further questions? Chairman Sapiki.
Just for clarification, Mr. Chairman, an MCO that doesn't want to abide by this law, they could still do business in other states without a problem, correct?
As currently written, that's my understanding, yes.
And if an MCO doesn't want to abide by this law, they can still offer insurance in Tennessee. They just can't be an MCO. Is that correct?
What, would you repeat that?
If an MCO does not want to abide by this law, they can opt out of being an MCO and still offer insurance in Tennessee. Is that correct?
Yes.
Thank you.
Representative Himmer.
Thank you, Madam Chairman. As part of the Affordable Care Act, there's a section 1557, which states that prohibits discrimination in healthcare on the basis of number of protected characteristics, including sex. How would this state law, be affecting that federal preemption?
Well, as far as I know, of course, under Tennessee law, this is defined as sex, your biological, and the type of definition you're talking about, as far as I know, is not covered under federal. So you're talking about sexual orientation or sexual choice. I'm talking about biological sex at birth.
Thank you. What would happen if no MCOs would be able to provide care due to this act? How would
There
we
are
administer it?
there are already plenty of MCOs already wanting to be one of the treasured 3 right now, so I don't think that would be an issue.
Any further questions? Representative Mitchell.
Yeah, Madam Chair, do we have any testimony from the public that have signed up for this?
Yes, we do.
Okay.
We're
Are we
go out
gonna
of session and
hear from those?
Yes, we are.
All right, thank you, ma'am.
We are now going to go out of session. We have 7 people here to testify. Thank you for joining us today. The first up is Ray Holloman from the Tennessee Equality Project. See here? Thank you for joining us today. You have 3 minutes for your testimony. Can you please introduce yourself and tell us who you're with for the record? I think your mic, is it on? Little red light.
Is that better?
Yes,
Okay.
thank you.
My name is Ray Holloman. I'm here with the Tennessee Equality Project.
Okay.
I am a Tennessee native, and I've lived in my home state for the last 32, almost 33 years. I'm also a transgender man, and I'm urging you all to vote no on HB 1215. TennCare already does not allow for gender-affirming services through the healthcare plans that are provided to Tennesseans. HB 1215 makes it so insurance companies who apply for the TennCare contract cannot be reimbursed for gender-affirming services anywhere in the U.S. Gender-affirming services are life-saving and should not be taken away in any form or fashion from the people who have it. This could lead to not having any managed organizations that are willing to contract with the state, as these organizations have to comply with the Affordable Care and Medicaid Acts. If TennCare cannot deliver services under the managed care model, the organization may be forced into the much more expensive fee-for-service model that would be much more expensive for the state to manage. There's also an additional impact on companies that offer gender-affirming services as part of their services that now could become potentially limited for insurance companies that they can use in this state to be able to provide these services. TennCare does not allow for gender-affirming services. What if the gain of this bill except to hurt Tennesseans who want to be able to use insurance that they pay for to provide the services that they need? This bill takes away necessary health care from transgender Tennesseans like me, while other Tennesseans can receive the care that they need. While only 1.6% of the population that is trans, a lot of focus is put on attacking the transgender community. This is just another prong of the attack against my community. With this bill, the way it's written, it only opens the state to additional lawsuits from insurers, residents, and the federal government. And as many have said, Once a person turns 18, they have the right to do as they wish, including transition. This bill flies in the face of those statements as well. HB 1215 is not good for anyone in this state, whether they are transgender or not. It will limit the bidding process for the managed care organization TennCare contracts or force the state into a fee for services if no one acquiesces to the no reimbursements for gender affirming services for any state or person. Everyone in this state deserves access to health care that they need. So again, I urge you to vote no on HB 1215 as it does not benefit Tennessee at all. Thank you.
Thank you. I'm going to ask you to remain seated, and I'm going to let everyone speak, and then we'll have questions. Next up is Seth Likens. Can you please say your name and who you're with for the record?
Hi, is my microphone on? Are we on? Hello.
Yes, you are.
Hi, I am Seth Likens. I'm representing myself. Good morning, representatives. My chosen name is Susie. I moved to Tennessee over a decade ago to attend Lipscomb University. I graduated in 2014, and I have since moved east of Nashville to live a rural country life. I'm speaking today to encourage you to vote no on House Bill 1215, which will prohibit gender-affirming care through TennCare. I am speaking as someone who receives life-giving gender-affirming care. In 2017, at the age of 24, I received a bilateral orchiectomy. For those who are unfamiliar with that term, I had both of my testicles removed. I had to go out of state to an informed consent urologist to receive this care. I did not have insurance at the time, and I had to sell my car in order to pay for my surgery. I was lucky that it was possible for me to be able to afford this care. Many trans people are not in a financial position to be able to do something like this. This surgery changed my life. It relieved me of a deeply uncomfortable bodily sensation that had distressed me for years. It increased my physical, emotional, and spiritual sensitivity. Because of the surgery, I can more clearly feel the presence of God. Like many of you, I was raised in Christianity. While I firmly believe in the separation of church and state, I understand that religious biases currently affect your legislative process. Thus, I must name the historical presence of eunuchs in the early Christian writings as examples of people who underwent bodily transformations and served in sacred roles that were granted high status and honor in early Christianity. In Matthew 19:12, Christ says, "For there are eunuchs who were born this way, and there are eunuchs who have been made eunuchs by other, and there are those who chose to live like eunuchs for the sake of the kingdom of heaven. The one who can accept this should accept this." Christ carves out a space for eunuchs to exist within his theology. Christ names the importance and power of eunuchs as a part of the kingdom of heaven. While it is incorrect to call the eunuchs of biblical times trans people, they are clearly described as people who exist outside of a traditional gender binary, who have elected to undergo bodily transformation for the glory of God. The parallels to contemporary trans people are evident. Trans people are sacred. We bridge the space between male and female and serve to integrate disparate parts of our communities. Trans people deserve affordable access to healthcare that allows us to express our sacred blessings. Limiting insurance access will create a system where only wealthy trans Tennesseans are able to afford transition, leaving behind poor and working class trans people. As Christ says, "Blessed are the poor, for they shall inherit the kingdom of heaven." Trans people of all economic classes deserve access to gender-affirming care. I pray that trans people are blessed, supported, and funded by state insurance in our sacred medical transitions. Thank you for your service.
Thank you. Next up is Ocean Ray. Please state your name and who you're with for the record, please.
Hello. Good morning, afternoon. My name is Ocean Ray, and I'm representing myself. I'm not with an organization at this point in time. I'm a resident of Tennessee, DeKalb County. I'm a registered nurse, and I'm a trans person who receives gender-affirming care. I'm urging you all to vote no on HB 1215. In my role as a nurse, I've worked in hospitals all over Middle Tennessee. It is possible that I've worked with and cared for your family members, or maybe you when you were ill. If I did, I'm glad for that, because I always strive to care for people with love, respect, and dignity. Those are my values, and that is what is important to me. The values of all Tennesseans are not represented by this bill, Representative Rudd. I'm a fierce advocate for all of my patients getting the care that they need. We are all, each one of us, me, Susie, Representative Rudd, Chairwoman Haynes, worthy and deserving of care. For me, that is not a difficult concept. I am inspired to care for people by the ways that my community and family care for each other, the ways that I've seen that care demonstrated in the world, and in the teachings of spiritual leaders. That care is an expression of my love for humanity, my belief in all of our inherent goodness, and my gratitude for being here on earth at this time and able to care for people. I believe that when the most vulnerable among us are cared for, we are all cared for. Whether the source of that wisdom for you is Matthew 25, the Bodhisattva vow, or Black feminist wisdom, the message is the same. I ask you this, is it not absurd for a legislative body to assume the ability to pick and choose how people receive life-saving medical care? I'd also like to ask why limit life-saving care for trans people? I'd like to ask, when and where does that reach end? To me, it feels like a slippery slope. I'm a trans person who's created a life and a home in Tennessee for the last 15 years. I'm from rural Georgia, and I love living in rural Tennessee. I feel like the land knows me, and I know the land, and we care for each other. Trans people have existed since the beginning of human existence. We have been healers, spiritual leaders, performers, caregivers, and we have worked with the land. We are all, not just trans people, in this life made to feel like we don't belong, that we have to be perfect in order to be worthy of love and care. The truth is we are already perfect. We have just at some point internalized a message that we aren't. Regardless of what happens with this bill, trans people will exist. We will thrive. We will access health care, and we will care for each other because we always have. Representatives, I pray for you all daily. I pray and I hope that you all have what you need in order to feel safe and whole, that you access the love, care, and support that is available to you. I pray that you will find and nourish your own humanity, and I pray that that is a humanity that does not need to deprive, terrorize, and oppress others in order to feel justified in its existence. May it be so. Thank you.
Yes, red button.
Okay, is that better?
Yes.
Okay, great. Hello, my name is CJ Desai. I'm not with an organization. I'm an acupuncturist, nationally certified and licensed in the state of Tennessee, a divinity school student here in Nashville, and a person who receives gender affirming care. I'm here today because I oppose HB 1215. I've worked in a medical clinic that provides gender affirming care to trans people, and I have focused my career in acupuncture and now chaplaincy on providing care to underserved people like low-income folks, veterans, and transgender people. I sat down to write this testimony and tried to settle on an approach. I could gather and quote statistics about the high rate of suicide among trans kids and adults who are unable to receive gender affirming care, or make a list of all the credible medical organizations that support gender affirming care for people of all ages. But I know you've heard that. I could tell you my own story or one of hundreds of stories that I know from being in trans community and working with trans people about the importance of this care. But you've already heard those stories too. There is no medical treatment that is 100% successful, but for the vast majority of those who receive it, roughly 98%, gender affirming care is life-giving. Taking this care away from vulnerable populations is then life-taking. When transgender people come here to speak for ourselves, it's not political, it's personal. I spend my days trying to get an education, make a living, care for my community and my family. I do not spend any time thinking about how to maintain my rights, but it seems there are people who spend a lot of time thinking about how to take them away. In trying to maintain access to adequate health care, we are not trying to remake anyone else in our image. We are only trying to imagine a future for ourselves. I wonder if the people who support this bill can say the same thing. If we stop showing up in these hearings, it won't be because we don't care anymore or because we cease to exist, but because we lost hope. hope that we can have access to the same rights given to any other resident of the state of Tennessee, but we will still be here. My hope is that you will listen to the people this law affects, not people who don't know anything about us, to professionals, not podcasters. My hope is that you will listen to experts. This includes parents of trans kids, transgender people of all ages, and current, credible medical science and healthcare professionals. Thank you.
Thank you. Next, we have Malcolm Brown. Please state your name and your affiliation.
Hello. My name is Malcolm Brown. I'm here with myself.
Thank you.
I bring into this room the following intersecting identities. I'm a Protestant Christian pursuing a master's in divinity. I'm a heterosexual African-American cisgendered man. I'm a diversity, equity, and inclusion professional. I'm a citizen of this nation, and I'm a resident of this state. Today, I'm here to speak in opposition of HB 1215. TennCare's stated mission is to improve lives through high-quality, cost-effective care to support the vision of a healthier Tennessee. TennCare acknowledges that in accomplishing this mission and vision requires partnership between the provider community, stakeholders, advocates, families, and TennCare employees. Today, I am here to advocate for lives to be improved and for a healthier Tennessee. Doing so means we must ask the question, what is a healthier Tennessee? How is it possible for us to separate the health of the state from the well-being of its people? If our mission is to improve lives, how does the care we provide or withhold reflect that commitment? On what grounds do we qualify our right to determine the standard of care people are entitled to receive? To dictate who is and is not worthy of care, whose distress is or is not worthy of attention, starts us down a path from which we will never realize the stated mission of TennCare. All lives are worthy of being improved. When asked which was the greatest commandment, in Mark 12, Jesus replies, "Love the Lord your God with all your heart, with all your soul, and with all your mind, and with all your strength," before adding, "Love your neighbor as yourself," concluding that there is no commandment greater than these. In reading this passage, I find most convicting what we are commanded to do. When asked who our neighbors are, Jesus tells the parable of the Good Samaritan. In the parable, the title character shows mercy to a stranger unable to fend for themselves, providing care and ensuring well-being. To speak of loving our neighbors as ourselves while refusing to recognize the dignity of and care for those we perceive as different is a false religion. I'm here in opposition of this bill because its mandate is to deny care. I'm here because I believe it is necessary and just to speak out against systemic evil and abuses of power. I'm here as witness that not only trans people care about trans people. Thank you.
Thank you. Next, we have Lynn Purvis. Please state your name and who you're with for the record, please.
My name is Lynn Purvis, and I'm here representing myself.
Okay, I think your microphone, you need to turn that on.
Okay, it already had a red light. My name is Lynn Purvis, and I'm here representing myself. I also live in Cannon County. I'm also a cis woman, and I am a court interpreter in the state court system. So speaking of courts, I'm going to kind of review some of the things that have happened in the courts over the last couple years. In 2020, the U.S. Supreme Court decision in Bostock versus Clayton County clarified that discrimination based on sex includes sexual orientation and gender identity and is prohibited by federal law. Last year, the U.S. Department of Health and Human Services, they published guidance clarifying that Section 1557 of the Affordable Care Act prohibits discrimination on the basis of gender identity in access to covered health programs and activities. And I'm going to quote here, "A provider's view that no gender transition or other gender affirming care can ever be beneficial for individuals, or its compliance with a state or local law that reflects a similar judgment, HB 1215, is not a sufficient basis for a judgment that a health service is not clinically appropriate." An explicit, categorical exclusion or limitation of coverage for all health services related to gender transition is unlawful on its face. And that's a quote. Now, in June of 2021, the ACLU, on behalf of 2 transgender women, sued the Georgia Department of Health for denying Medicaid coverage of their gender-affirming surgeries. The suit alleged violation of the U.S. Constitution, the Affordable Care Act, and the Federal Medicaid Act. The lawsuit settled last year with Georgia's Medicaid plans agreeing to adopt benefits and clinical guidelines for the treatment of gender dysphoria, including benefits for gender-affirming surgery. And then they had to pay $350,000 to the plaintiffs on that suit. In CP versus Blue Cross Blue Shield of Illinois, this was a class action lawsuit that was brought on by a woman and her 16-year-old transgender son. He was 15 at the time, I believe, of the denial of services. And a U.S. District Court in Washington State concluded in December of 2022, just a few months ago, that because a health insurer received federal financial assistance, all of its operations were subject to Section 1557. The judges said, quote, Blue Cross, as a third-party administrator, is a covered entity under Section 1557 and has discriminated against the class plaintiffs by denying them services for gender-affirming care under their insurance policies. They were ordered that if they were going to provide health care, they must provide gender-affirming care. So it's crystal clear that there is no legal standing for this type of exclusion of services. And I again ask, what adequate MCO are we going to find that is not receiving federal funds? And I also wonder, how can TennCare itself, as a Medicaid program, which I understand to mean receiving federal funds, how can they categorically exclude protected health services? Down the line, or is this going to be a matter of having to reject federal
Ms.
funds?
Purvis, I'm sorry, your time is up.
Could please wrap my last sentence up? Our state lawmakers so dead set on shunning trans people that they're willing to face, lose, and pay for lawsuits by passing an obviously illegal bill. This is not a smart insurance decision, just another stab at trans people in our
thank you.
state. We will continue to love, support, and affirm trans people. Happy Valentine's Day.
Next up is Juliet Allen. Does someone mind changing places with Miss Allen? Thank you. Please state your name and who you're with for the record.
My name is Juliet Allen, and I'm with myself.
Thank
you. My name is actually River. I live in the small town of Liberty, Tennessee. For the past 5 years, I've been working as a caregiver for a trans elder who is bedridden and her 84-year-old husband. That's in Woodbury, Tennessee. I recently had a legislative visit with my state representative, Michael Hale, in order to communicate to him the deadly damage that HB 1 would have on my community. This was the first bill attacking gender-affirming healthcare for youth, and clearly the bill was not about protecting children from irreversible changes to their bodies. Children can legally get liposuctions, calf implants, nose jobs, breast enhancements. This bill was about eliminating trans people while they were still children. And now HB 1215 confirms that this was never about children in the first place. During our talk, Representative Hale speculated that the reason why so many trans people in the USA lived in the South was because Southern communities, and especially rural Southern communities, were welcoming and inclusive. And it honestly tugged at my heart to hear him say that, even while it was delusional. I love my home. The small wave that rural folks give each other when we pass each other on country roads, the way people who do not necessarily understand my identity will still give me the best gardening advice at the farmer's co-op. But in Tennessee, there are no state or local non-discrimination policies that protect LGBTQ people. And now the state legislature has passed dozens of laws that directly attack trans people. Gender-affirming healthcare was already difficult to access. Now, by making these expenses out of pocket, you will force many to self-manage our own care at great risk without the support of doctors. Your denial of trans people's existence or validity does not make us cease to exist in the state of Tennessee. As you must already know, there's no legal standing for blocking TennCare MCOs from covering gender-affirming care or choosing not to have MCOs that do so. Similar efforts have lost court battles in other states because they violate the Affordable Care Act via Section 1557 and the Federal Medicaid Act, amongst other things. Today, vote no on HB 1215. Show us that you are more interested in passing good, sound policy that's well-crafted and thoughtful for the benefit of every Tennessean than in scoring political points to satisfy a far right-wing extremist base. Thank you.
Do we have any questions or comments from the committee? Representative Mitchell, you're recognized.
Yeah, Mr. Malcolm Brown, is that correct? Hey, I appreciate you coming here today and your statements. A lot of what you said was not any legal statements, is a basis of hopefully how many of us form our morality. And, you know, those were the statements you made, and most were from Christianity, were not legal statements, like I said, but probably reason why I ran for office. You know, I ran for office to help people and to give more people care, you know, to give more Tennesseans care, not to take things away from people. So with what you said, I hope a lot of the committee listened to you and thought to themselves, hey, that's how I formed my reasoning for the reason I ran in the first place. And with that being said, I'm not going to argue this bill very much more because the speaker after you made it quite clear this committee can pass it, the next committee can pass it, we can pass it on the House floor, it can be signed by the governor, but the first light of day in a court it sees, it's going to be thrown out in about 5 minutes. So with that being said, I'm done. Thanks.
Any further questions? We are back in session. Chairman, do you have any further discussion on the bill? I'm sorry, witnesses, you are dismissed. Thank you. Chairman, you're recognized.
I just want to say that this bill does not deny treatment. It does not deny access to the transgender community or any community to health care. They can still, if they need medical treatment, if they need counseling for this, or if they have a broken leg, or if they have other COVID-19 or other, they can still receive treatment. To deny them treatment based on being a transgender would be discrimination. This bill does not discriminate, and it also does not outlaw the surgery, as it has in some states. It just simply states that Tennessee tax dollars are not to be used for it. Very plain, very simple. And I think that that speaks to the bill itself. It's a very simple bill, what it does, and regardless of what has happened in Georgia or other states that go well beyond this bill is very narrowly defined.
Do we have any questions from members? Representative Hemmer.
Thank you, Madam Chairman. I was wondering if it's possible to hear from TennCare on this bill.
They didn't ask to testify.
They are not signed up, so no, I'm sorry.
Okay. I would like to request the TennCare officials could please check with legal after reading this. In Section 1557, I was just curious how this legislation would affect our federal funding for TennCare. Thank you.
Thank you. Any further questions? We are now voting on House Bill 1215. All those in favor of sending House Bill 1215 to insurance full signify by saying aye. Opposed? The ayes have it. Bill goes to insurance full. Item number 2, House Bill 1213 has been rolled 1 week. House Bill number 3, House Bill 152 by Chairman Hazelwood. We have a motion and second. Do you have an amendment?
I do have an amendment that makes the bill, Madam Chairman. It's drafting code 3793.
We have a motion and a second on the amendment. Chairman Hazelwood, you're ready to speak on the bill as amended.
All right, and the amendment, as I said, does make the bill. This bill is the hospital assessment bill that we have been passing and dealing with since 2010. And I think the bottom line about this bill, it'll bring $1.8 billion to the state for TennCare services. There are a couple of changes that I'll go through. As I said, it was first passed in 2010, and this year's bill continues the current assessment rate, which is 4.87%. That is not changing, but the 2023 assessment is based on data from the 2019 Medicare cost report. Previously, that information was based off the 2016 Medicare cost report. And as we all know, in 3 years, many things have changed. That's just the latest numbers that we have. So that's what we're dealing with. The change is necessary to realign revenue with costs so that we can continue to cover services that are provided to the TennCare population. I think it's worth noting that over the last 12 years, the annual amount of funding for the items that THA continues to cover has increased by $294 million, and hospitals have funded a total of $139 million in just growth alone. All money, for those of you who are new on the committee and maybe new to this legislative body, but all of the money collected under this assessment goes into the trust fund to provide the state share of funding for the TennCare program. In order to do this, the reason this program was implemented in 2010 was to prevent cuts that otherwise would have had to be made in TennCare services, would have included things like hospital, physician, and health professional rate reductions. And we know if you hear from your physicians and your doctors, that's redundant, from your physicians and hospitals and other providers at home, then you know that TennCare rates are, none of the providers think that they're where they need to be as is, much less to be cut. It also provides funding for critical access hospitals, particularly public hospitals that are providing charity care. So this legislation would also, this is important point, again, for those who've not dealt with this before, but the legislation is specific in that this does not allow the hospitals to pass this assessment through. It is not a pass-through to the end user. It specifically says that no surcharge to patients can result from this assessment. And again, that's been part of the bill since 2010. And this amendment, this particular year, also includes language that will provide some immediate one-time assistance using assessment dollars that are available due to the enhanced federal match during the pandemic to offset charity care costs, which, as most of you know, again, if you hear from your hospitals at home, from your providers, that those costs have gone up. With that, Madam Chairman, I would take any questions.
Okay. We are actually going to vote on the amendment. So all those in favor signify by saying aye. Aye. Opposed? The ayes have it. The amendment is on the bill. Does anybody have any questions for Chairman Hazelwood? The question has been called. All those in favor of sending House Bill 152 as amended to insurance full signify by saying aye. Aye. Opposed? The ayes have it. Bill goes to insurance full.
Thank you, Madam Chairman. Thank you, committee.
Item number 4 is House Bill 893 by Chairman Reedy. We have a proper motion and second. Chairman, you're recognized on the bill.
Thank you, Madam Chair and committee. And this is my annual pilgrimage to this committee for the ground ambulance to extend them for another year. And for the sake of our new members, let me explain. Patience. The ground ambulance assessment was created in 2018 to help fill the gap between the expenses incurred by ambulance services to perform a transport and what Medicaid reimbursements for this transport. Without using any state dollars, the ground ambulance service pays into a fund that draws down over $20 million in federal funds that is then paid back out to these services based on their Medicaid transport. House Bill 893 will extend the ground ambulance assessment for another year. please do.
Any questions
Madam
from the
Chair.
members? Seeing, question has been called. All those in favor of sending House Bill 893 to insurance full signify by saying aye. Aye. Opposed? The ayes have it. Bill goes to insurance full. Item number 5 is House Bill 371 by Chairman Darby. We have a motion and a second. Chairman, you're recognized on the bill.
Thank you, Madam Chair and committee. House Bill 371 was brought to me by the Tennessee Disability Coalition and seeks to amend the ABLE Act. In 2015, the General Assembly passed the ABLE Act, which gives people with disabilities the opportunity to save and invest in a tax-free savings account that helps them maintain independence and improve quality of life. This bill gets the estate recovery claim in line with what CMS currently requires, that only allows for TennCare to do an estate recovery claim for those who pass away that are 55 and older. The Treasury's Office and TennCare are both okay with this bill.
Any questions from the members? The question's been called. All those in favor of sending House Bill 371 to insurance full signify by saying aye. Aye. Opposed? The ayes have it. Bill goes to insurance full.
Thank you, Madam Chair and committee.
Item number 6 is House Bill 355. It's been rolled 1 week. Item number 7 is House Bill 1318. It has been rolled for 2 weeks. That concludes our calendar. Before we close, does anyone have any announcements? Do I have a motion to adjourn? We are adjourned.